As we know, craniopharyngioma is a rare brain tumor that is considered benign, but unfortunately is associated with side effects including vision loss, metabolic issues, loss of hormone function, and impact on growth and development. Survivors often experience significant quality of life challenges. The Craniopharyngioma Disease-Specific Working Group aims to develop clinical trials to provide better therapy options that result in long-term survivorship with less impact on daily function and quality of life. Today, Drs. Kiine and Malbari will be sharing information about the work they are doing in this area. Dr. Kiine is the Director of Neuro-Oncology Clinical Research at CHOP. She completed her residency in pediatrics at CHOP, followed by a fellowship in pediatric hematology oncology at the University of California, San Francisco, where she also completed a master's in clinical research and subsequently served on the faculty. Her focus is clinical research and trial development for pediatric brain tumors. Dr. Malbari completed her undergraduate and medical education at Rensselaer Polytechnic Institute and Albany Medical College through the Accelerated Physician Scientist Program, where she received a distinction in research. She completed her pediatric and child neurology residency training at Cohen Children's Medical Center, Hofstra Northwell Health School of Medicine. She then completed a fellowship in pediatric neuro-oncology at the Memorial Sloan Kettering Cancer Center. Dr. Malbari's clinical interests in area of research include CNS tumors and patient-reported outcomes. Welcome to you both, and thank you so much for talking with us today. I will turn it over to Dr. Malbari.
Thank you, Amy, for that wonderful introduction and for giving us an opportunity today to speak at the pre-conference for the Pituitary Brain Tumor Conference, or the pre-conference workshop. We hope you find this useful. And before we actually kind of get started today, I just wanted to poll the audience and get an idea where everyone is from. So if you wouldn't mind, could you please respond to this question? I think we have a couple more that we're waiting on. So it sounds like we have a pretty good representation. We have some people from Europe, which is wonderful, and Canada and East Coast. So welcome everyone. And again, thank you for joining us. So I'm gonna... Sorry, technical difficulties. There we go. Okay, so what I hope to kind of talk about today and kind of what the goals of our talk today are to provide an overview of the current biology of craniopharyngioma, to provide an overview of the potential options for targeted therapy, and to introduce an upcoming clinical trial that we are working on for patients with newly diagnosed or recurrent craniopharyngioma through the Pacific Pediatric Neuro-Oncology Consortium. So for those of you who may not be aware of PNOC, it is an international consortium with 19 sites in the United States, and then there's sites as well in Canada, Australia, and Europe. And the goal of the consortium, as Amy mentioned, is to test new therapies that are specific to the biology of tumors to help with overall improvement of outcomes. So I'm sure all of you are very well familiar with what's on this slide from firsthand experience, so I won't go into too much detail, but I just wanted to briefly give you all an overview of craniopharyngioma. So it's a rare pediatric brain tumor representing 2 to 6% of all pediatric brain tumors. And when we look at the tumor under a microscope, there's 2 different types that we can see. There's something called adamantinomatous craniopharyngioma, which from here on forward I'll refer to as ACP, and papillary craniopharyngioma, which we'll refer to as PCP. So ACP is the more common subtype and is the one that is seen in children as well as in adults, and the papillary craniopharyngioma is the more common subtype that's seen in adults. These 2 subtypes have different appearances on MRI, where ACP typically have a cystic or fluid-filled component, and PCPs are generally more solid. Treatment for both of these are the same, which basically is, when possible, maximum safe gross total resection versus partial resection followed by radiation therapy. And the cystic component of these tumors can often be very challenging to control, as our current standard treatment options are not always helpful in treating the cystic portion of these tumors. And unfortunately, craniopharyngiomas can recur and often recur up to a third of patients within 3 years of diagnosis. And at the time of recurrence, our treatment options are limited. We basically have the same options that are available at the time of initial diagnosis, and sometimes delivering those same treatments are challenging because of the prior therapies that patients have already received. And so, as you all know, the tumor and the location of the tumor and the treatment that we currently have to treat craniopharyngioma causes significant side effects. So a lot of these patients will experience vision loss, hormonal imbalances such as diabetes insipidus, growth and development issues like obesity, stroke, difficulties with learning, comprehension, neurocognition overall. So there's a problem with, okay. So part of the reason why we don't have other treatment options or limited treatment options is because of the lack of knowledge about what causes craniopharyngioma, what causes it to recur despite treatment. But thanks to global efforts, we have been learning a lot more about the biology of these tumors and have been able to identify different pathways that are involved or active in craniopharyngioma, namely the inflammatory pathways, immune response pathways, and molecular or cellular pathways that make up these tumors. So this image is just an overview of some of the different things that we've learned over time. So as we mentioned previously, there's two different subtypes of craniopharyngioma, ACP and PCP. And in ACP tumors, there's often a mutation or a change in a gene called CTNNB1. And this gene produces a protein called beta-catenin, which I will talk about a little later. In PCPs, the most common mutation that we can see is something called BRAF V600E. And the BRAF gene is involved in cell replication or growth. And again, we'll talk about this a little bit later. What we've also learned is that with ACP tumors, they can be further subdivided into two different groups based on the behavior of the tumor. And what I mean by that is, even though they don't have this mutation, the BRAF mutation, what we found is that some of these tumors will behave similar as if they have that mutation. In addition to that, we've also learned that there's differences in the different components of the tumor. So there's differences in the solid and the cystic compartments of the tumor, which is helpful in coming up with different treatment options. Okay, so the next few slides, we're going to focus on the cellular pathways that are involved in craniopharyngioma. And in particular, this slide is focusing on ACP craniopharyngiomas. So as I mentioned earlier, the most common mutation you can see is something called CTNNB1, which produces a protein called beta-catenin. And that protein is external to the cell. So to orient you, here is outside the cell, this is the cell membrane, inside the cell, and the nucleus of the cell where replication occurs. And so when you have this mutation in that specific protein, basically what happens is you get an upregulation, or the pathway that's involved, which is the Wnt pathway, becomes overactive. And this pathway is involved in replication and growth. And so when you have an abnormal or a mutation in the CTNNB1, you get an abnormality in the binding of beta-catenin to other proteins. So what happens here is that normally beta-catenin will bind to a protein called GSK, and that will break down the beta-catenin. But when you have this mutation, GSK can no longer bind to beta-catenin, and this causes that pathway to become more active, causing more cell division or cell replication, leading to growth of tumors. What we also know is that in addition to that specific pathway being activated, that ACPs will behave very similarly to, or a subgroup of ACPs will behave very similarly to other tumors with the BRAF mutation. So you can see here in light yellow is craniopharyngiomas that have a similar behavior to tumors that have this BRAF V600E mutation. And then the other subtype, which is actually not as common as the BRAF-like subtype here. And this is helpful because in terms of thinking about targeted therapies, we could use drugs that focus on the BRAF mutation as a possible therapeutic option for patients with ACP, even if they don't have that specific mutation. And then what I wanted to just mention, going back, sorry, one slide, is that with this particular pathway, there are some drugs that are being investigated currently to target the Wnt pathway, but nothing yet that's out there in terms of clinical trial or availability. Okay, so molecular or cellular pathways with PCP tumors. So as you all heard, the most common mutation that we see in this pathway is with the BRAF mutation. And BRAF is a gene that is involved in cell division. And so when it's normally functioning and you have outside of the cell growth factors that bind to start the process of cell division, you get normal cell division and normal cell growth. But in the setting of a BRAF gene that's mutated, what happens is that it basically causes, turns on and stays on and causes this pathway to continue and cause increase in growth and cell replication, regardless of whatever is happening outside of the cell. So even if you don't have stimulation from outside the cell to start this pathway, the pathway just remains on and continues to cause cell replication. And as you can see here in the pathway itself, there's other kind of points along the way that are involved in cell replication and can all be potential targets for treatment. So to break this down a little bit more, as we talked about the different things that we can potentially look at to address craniopharyngioma from a cellular pathway, when you look at outside the cell, there's two things that we can potentially focus on. What the Wnt pathway is the one that we talked about. And then when you go inside the cell, the pathway of cell replication starts at this first step, which is RAS. But then there's other steps in that pathway that are involved in cell replication, the second step being the BRAF pathway. And there are two drugs that are available right now to use, which will basically block this mutated gene from causing cell replication and growth. And then if you go down to the next step, kind of in that pathway, downstream of that pathway, there's another protein called MEK that can be, or another pathway called MEK that can be targeted with drugs such as J101, trametinib, and selumetinib. And then one step further, there are some drugs that are currently under investigation for this particular part of the pathway. As we speak, there's actually a adult clinical trial for PCP craniopharyngioma looking at combination therapy of vemurafenib and cobimetinib in patients who have PCP craniopharyngioma. Okay, so we're going to switch gears a little bit now and talk about the inflammatory pathways of ACP. And what we've learned is that by looking at the cystic fluid of ACP, that there have been markers of inflammation that were identified, namely IL-6, and you can see that here. There are other markers of inflammation that were also identified, but IL-6 was found to be the most prominent marker. And what we also know is that this inflammatory pathway plays a role in both the cystic and the solid components of craniopharyngioma. And so, again, to orient you kind of down here with the slide, with the cell. So the area over here is outside the cell, this is the cell membrane, and then this is inside the cell with where cell replication and division occurs. So IL-6 is a protein or an inflammatory protein that is outside of the cell and is found outside of craniopharyngioma cells. And when it is present, it will bind to its receptor, which is this IL-6 receptor. And that interaction basically turns on two different pathways. And both of these pathways are involved in cell replication. So when this occurs, you get cell growth basically because of activation of this IL-6 binding to its receptor and causing these two pathways to turn on. And so what we are looking at is using drugs to target IL-6 and its receptor to basically stop this pathway from being turned on and causing cell replication. So the two different kind of targets that are being investigated currently to look at the inflammatory pathways is targeting a drug specifically targeting IL-6, the inflammatory marker, and then using another drug called tocilizumab, which is an inhibitor of the IL-6 receptor. So by targeting both of those, we could potentially stop the pathway from being turned on and causing cell replication. And so what we know about these two drugs is that at least tocilizumab has already been sort of looked at in patients with craniopharyngioma, and it was used to treat two pediatric patients who had pretty cystic predominant craniopharyngioma. And in those two cases, it did seem to control the growth of the cystic portion of these tumors. And so with that data, they're moving now up front to create a clinical trial using tocilizumab with another drug, a MEK inhibitor, which would target the cellular pathway of these tumors. And interestingly, both of these drugs are actually getting a lot of attention these days in the media because they're also being looked at to target pulmonary complications from patients with COVID. And so I think we're going to stop there and do our second poll before I hand it over to Cassie. So if you wouldn't mind pulling up the second poll, I think a lot of what we're doing is to try and help improve outcomes for patients and bring better quality of life. And part of our, what we would like to do is to get more information from you guys as to what you would think would be the most opportune or the best therapeutic options that we should be looking at. And so we'd like to know what would be considered more important for you and your family: to receive treatment with the best chance of low tumor recurrence at any cost, or to receive treatment that would potentially increase the chance of tumor coming back but have a better quality of life. So if you could take a couple of seconds there and answer this question for us, I think it would be really helpful moving forward just in terms of designing better clinical trials for this patient population. So I'm going to end the polling. But thank you for being honest. I think it's very helpful for us to have this information so that we can kind of move forward with creating our trial using this information. And I don't know if I can share the results of the poll. And Cassie, I'm going to hand it to you.
Awesome. Thank you guys. And thank you, Fatema, for getting this started off. It looks like there's some queries in the Zoom chat. And so I think that we'll try to get these resolved if people can't find the polls so that we can make sure that everyone sees the results. But as Fatema was saying, can you guys hear me okay, Fatema?
Yes.
Okay, great. It seemed a little frozen for a minute. But as Fatema was saying, what is paramount to us as we design these clinical trials is really the input of patients and families in terms of how we're designing our clinical trials, what drugs we're bringing to patients, and then of course how we're measuring success ultimately. So on that note, I'll finish out kind of some of the biology of craniopharyngioma that Fatema got us started with. And specifically, I'm realizing it's probably, is that better? Is that the presenter screen that you guys can see now? Okay, great. And so we'll move on to the immune pathways. And, you know, one of the first slides that Fatema presented was really the number and variety of different pathways that over time we've now identified are active in craniopharyngioma. So we have the molecular pathway, which is really kind of changes at the gene level that drive this tumor to develop and then to persist potentially after therapy. And then we have these inflammatory components, which also seem to be contributing and making this tumor grow. And then separately, we have the immune pathways that we've now recently identified are involved. And what's interesting is that the other unique part of craniopharyngioma that is somewhat distinct from different types of tumors is that there's predominantly different compartments of the tumor. And so there's potentially cystic regions and then there's solid regions, which is unique, and not every tumor is like that. And what is important to think about when we're trying to think about targeting these tumors is that each one of these compartments of craniopharyngioma has a slightly different type of pathway that's involved or a combination of pathways that's involved. And so when we think about all of these different driver pathways to the tumor, that's where we start to think about the importance of potentially a combination therapy or bringing multiple drugs together so that we're hitting multiple compartments and multiple pathways within craniopharyngioma. So this pathway here in terms of immune pathway, so this has been brought together with a lot of work from different labs all over the world really, and looking at what the craniopharyngioma samples look like from an immune standpoint. We know that the body's own immune system is meant to combat foreign things in the body, and that includes tumors. But tumors are very smart, and they found ways to turn off the body's immune response and to bypass it and to grow and develop and progress. And so one of the ways in which we want to try to figure out how to target these tumors like craniopharyngioma is how do we make it so that we cut off that messaging to the immune system and we allow potentially the body's own immune response to target the tumor. And what's interesting is what we're looking at here is a very busy screen and it's slightly complex. But the big picture is that our group, in collaboration with the Children's Brain Tumor Network, and then also in collaboration with an NCI-driven, National Cancer Institute-driven focus on proteomically characterizing brain tumors. So in this instance, proteomics means basically looking at the immune profile, or the protein profiles in these tumors. And what we found was that when we looked at a cohort of craniopharyngiomas, we actually found there's an elevation in pathway components within PD-1, which is programmed cell death, and CTLA-4, among some other immune pathway components. The reason that these are important is that the tumor can actually create proteins in these pathways that tell the body's immune response not to attack it and to turn it off. And we've now developed drugs that we can block that messaging so that when these pathways like PD-1 and CTLA-4 are activated and there's messaging from the tumor to bypass the immune response, we now have drugs that we can give that can block that messaging. And it was very interesting and important to us to identify these pathways in craniopharyngioma, both to help us understand how these tumors are developing, how they're bypassing the body's immune response to combat them, and potentially ways in which we can target this. And so to further the evidence that we found, and then also based on foundation of research that was already existing, you know, again, these are somewhat complex slides, but the big picture is, you know, the diagram in the upper right-hand corner here is basically showing that we did special tests and dyes and studies to look for the pathway components in the tumor itself, right? So we found that we've looked at different compartments of the tumor, and we've actually found that here you can see within compartments of the tumor of craniopharyngioma, the brown really represents that these pathways and these proteins are there and active. And here, this looks at the expression of those pathways or of the activity of these pathways. And ACP stands for the adenomatous craniopharyngioma, which is the most common pediatric craniopharyngioma. And you can see that when you look across different types of tumors that significantly in craniopharyngioma, this pathway is very active. And this diagram over here to the right was put together by one of our colleagues, Todd Hankinson. And it's very, very busy, but it kind of just describes the multiple ways and the multiple immune-based pathways that we've now identified are active in craniopharyngioma and potentially ways in which we can target it. And I'm going to pause for a moment because it seems that there are some questions popping up in the chat box. So before I go ahead, I just want to comment that someone has asked, what is the horizon for having evidence that targeted therapies could be successful at controlling growth? So I want to circle back to this question because I think it's really important, and I think we're going to get to it in the coming slides when we start talking about the potential clinical trial that's coming out of this. So when we think about targeting immune pathways, similar to what Dr. Malbari was describing earlier, there's novel drugs out there that have already been in existence that have potentially proven to be successful in other types of tumors, and that we can build on that information when we think about how we're going to use it in patients with craniopharyngioma. So you can see across each one of these potential pathways that or immune components that we have found to be active in craniopharyngioma, there's drugs that we know that we have dosing guidelines for, that have been used in other pediatric settings, that have been used in adult settings, that have been used in brain tumors. And we can extrapolate some of that information and then carry that forward into a new trial focused on craniopharyngioma. And so bringing together all of this information, and again, we're really looking at data that's been collected all over the world from a variety of different labs, from our own collaborators and colleagues outside of our immediate collaboration, and really trying to think about how can we advance the field, how can we improve therapy options for patients with craniopharyngioma that not only have as good or better clinical survival outcomes as things like surgery or radiation, which we know are successful at controlling disease in many cases, but that also come with a lot of side effects and toxicities that Dr. Malbari described earlier. So how can we at least meet that? And then the other part of this, and tying back to the question that Dr. Malbari asked, which is, what's most important to our patients? Are we able to potentially risk the tumor coming back, but knowing that we have a possible benefit to improving the quality of life of these patients? And so that led us to think about how we can bring together these combination therapies based on the science that we know. So specifically, we've talked about now bringing together PD-1 inhibitors to target the immune pathway, and then RAF inhibitors to target that cellular pathway, the molecular pathway that Dr. Malbari described in the first couple slides. This combination has been done successfully in other tumors, and it seems tolerable and potentially has provided benefit. So we thought it would make clinical and scientific sense to bring it together for this patient population. But one of the ways in which we tend to have a pitfall in our clinical trials is that when something fails, we don't have the opportunity to identify why or how it failed. And many of this derives from the fact that we don't collect tissue after we have given a patient a drug. So we collect tissue, we confirm the diagnosis, and then we give them drug. And then the tumor grows again, and we say, this drug has failed, so we're going to throw it out and move on. But there's a lot of intricacies to treating these tumors that we should be answering questions about. Does drug get into the tumor? Is drug causing the effects that we expected to on these pathways that we just described? Is it because there's resistance that the tumor is developing and now bypassing these agents? So what we've put together with all of our colleagues is a trial looking at patients with newly diagnosed and recurrent craniopharyngioma. And one of the questions that I'd like to pose here as well is how many families and patients in the audience today are dealing with either recurrent or newly diagnosed craniopharyngioma? And so as we answer that question, I'll kind of keep going. But So across these disease groups, we want to be able to answer the biologic questions that I just posed by giving at least 1 dose of PD-1 inhibitor, 1 dose of a RAF inhibitor, or a combination, 1 dose of the combination therapy, prior to patients going to the operating room for their standard of care biopsy or tumor removal. Because we want to collect that information to see what the tumor looks like after we've already given a dose of therapy, so that we can isolate what is the effect that this drug is having on the tumor. Is it getting there? Is it causing downstream effects? It also gives us a baseline so that when the tumor recurs, and if the patient needs another surgery, then what we can do is we'll collect the tissue at that time and compare it to the initial tissue to see how the tumor's changed and how it's escaping the treatment that we're applying. And it sounds like, just so we know, some people can't see the poll, so we're working on resolving that issue. It looks like maybe there's some issues with the internet platform, so people on Chrome may be having some concerns. So we're trying to resolve that. So by doing this by what we call a surgically or biologically driven trial, then we gather more information beyond just trying a new drug, reporting on whether or not it works based on if the tumor recurs, and we more comprehensively answer this question about finding a better therapy. And so then at the time of surgery, for our patient population, we would like to continue therapy in a combination approach after surgery for those that have had a biopsy or that have leftover tumor, because we assume those patients are still going to need treatment beyond the surgery or biopsy. And so we would plan to do the combination treatment on the back end to try to treat their tumor. One of the goals of which would be to try to defer radiation, because we know that radiation comes with its own complications. So is there a way we can, at a minimum, avoid that or delay it? So we can delay some of the complications like neurocognitive injury, risk of stroke, neuroendocrine injury, and those types of issues. For patients that actually are fortunate enough to get the whole tumor removed, they will stay on our study so that we can continue to follow their function and their outcomes, but they don't necessarily need to continue drug on the back end. And so from there, I'll move into the recurrent phase of the study. But just to give a sense of the population that's in our audience today, the poll results that have popped up, you can, it has about 3/4 of the patients, of 76%, or audience members, I should say, that has a family member with initially diagnosed primary craniopharyngioma. About 10% have family members with recurrent craniopharyngioma. And then about 15% of the audience members are patients themselves. And of those, 10% have a primary or newly diagnosed craniopharyngioma, and then about 5% have a recurrent craniopharyngioma. And so moving forward with the recurrent arm of the study, it's very much the same. The one caveat I will say is we really wanted to make this trial open and available to all comers and really to any patient or family that wanted to participate. And so in doing so, that was part of the reason we wanted to offer it both at newly diagnosed stages and recurrent stages. Additionally, if patients that have recurrent disease that would not be due for a surgery or a biopsy, we don't want to exclude them from this opportunity to participate in a trial, should that be a good fit for them. So instead, what we will do is we will collect tissue that had already been collected for these patients at the time of their diagnosis, using what we call archival tissue that's usually just stored in a hospital. And we'll use that as their baseline. And then we'll go ahead and enroll them on study and offer them the therapy, the combination therapy, but then also potentially repeat surgery if they need to in the future. And then we still are able to benefit from kind of this baseline tissue comparison to the post-treatment tissue comparison. And then I see another question coming up saying, is the PNOC clinical trial available only to patients in the US? And so that's a great question. And the benefit of the Pacific Pediatric Neuro-Oncology Consortium is that although it started several years ago as only a domestic consortium within the US, we've now expanded to international sites. And so we do have sites in Europe and Australia and Canada. We're also expanding to India. And so we aim to expand this trial opportunity across the globe as much as possible. The other part about this is we don't want to limit it only to PNOC member sites. So we have reached out to collaborators in Germany, as well as other sites or groups that may have interest and may have patient populations where they think could derive clinical benefit from this. Certainly, as trials roll out, it does tend to open first in the US, but in parallel, we'll be working to open it in other sites. And then the other question I see is, it was mentioned that the presentation of cranio is unique, including solid and cystic components. Is this similar to any other tumor types? Is it possible for cranio to be misdiagnosed as another type of tumor, like a low-grade glioma, or is it truly a unique tumor type? And so that's another good question. And certainly, I think a low-grade glioma is a very good comparison in terms of having both solid and cystic tumor compartments, because that is typically what we do see when we think about other tumors that have kind of these different compartments. And I think low-grade gliomas and cranios are somewhat unique in that regard. But there are certain characteristics, and the anatomic location of craniopharyngioma makes it very unique and makes it more or less likely, I should say, to be misdiagnosed. That being said, we usually still get tissue to confirm the diagnosis and just make sure that we're approaching this the best way possible. But I think that's a very, very good question. But typically low-grade gliomas occur in different anatomic regions, which gives us a signal as to what we may be working with. Okay, so just moving ahead. So as I talked about, obviously it's paramount to us that we're not giving a treatment that isn't going to offer the same survival benefit that has previously been shown with other treatments. But we really wanted to highlight the importance of quality of life in our patient population. More than 90% of patients with craniopharyngioma go on to live very long lives, but it comes in many cases at a very great cost of neuroendocrine deficits, of vision issues, neurologic complications. So what we've done is we're actually planning to incorporate both the measures of disease control and quality of life into our outcomes and bring those points together so that ideally we're finding a therapy that is effective at controlling disease and providing patients a good quality of life. Because without having that balance, then to us, just maintaining disease, but patients and families are just truly suffering from impacts on quality of life and function, that's still not a win in our mind. So we really want to bring together those outcomes for this patient population and ideally try to find those therapies that provide both. And so then the last thing I'll comment on, one of the things in which some of the audience members can be on the lookout for is, as we discussed, it's really paramount to us, and certainly by doing some of the polling within the context of this Zoom webinar, it's really important to us to find out how can we as clinicians, how we as researchers, how we as scientists can meet our patients and families' needs and goals. And so we've been working really closely with the Raymond A. Wood Foundation and with Amy to put together, different types of surveys that we can send to patients and families and really hear from them and get information about what's most important to them. What considerations should we be thinking about that we need to be incorporating into our clinical trials from a therapeutic and from an outcome standpoint. And so we will be circulating this in the next couple of weeks via email or via direct clinic visits at some of our various sites. So absolutely just be aware of this, and certainly please, we encourage you to participate if you get this, the opportunity to do so. And I think we're going to be transitioning into our discussion, but there's one more question that says, how long does the first dose take? Do you expect any tumor growth control from the first dose? So that's a good question, and I think that's something that we just don't know. One of the unique things about immune-based therapies is that sometimes from an imaging standpoint and even from a symptom standpoint, things can actually look a little bit worse before they get better. And the reason that is because you can imagine when you have a cut on your arm and all of a sudden an immune response is going to it, things get red, they get inflamed. And so the same thing can happen against tumors. You can get local swelling and local inflammation. And so things can actually get a little bit worse before they get better. But we don't know yet what that's going to look like for craniopharyngioma. And we certainly don't know how long it will take to see an effect. Some of the other drugs using RAF inhibitors in low-grade glioma, it does take several cycles before we see an effect. But certainly we're going to be monitoring very, very closely the symptoms and the imaging for all of our patients to make sure that we are monitoring some of these things exceedingly diligently. So lastly, before we move to discussion, I just want to say, and on behalf of myself and Dr. Malbari and all of our collaborators, we just really are truly thankful for our patients and families. And then these are some of the collaborators, certainly not all of them, that we've worked with, PNOC, the Children's Brain Tumor Network, and Advancing Treatment for Pediatric Craniopharyngioma as well, working with Dr. Todd Hankinson, working with Dr. Brian Root at Children's National Medical Center as well. So we're just very appreciative of all the work that's come together to present this work to you today.